negative evidence. -A would be strong evidence against the medication. And based on that, we have the grade of recommendation, and these are from 1 to 4, and grade of recommendation 1 would be a strong recommendation for using a certain intervention. Now, what were the results? For anorexia nervosa, we identified 70 relevant articles, and olanzapine was the most promising medication in a dose between 2.5 and 10 milligrams. We identified 4 positive randomized controlled trials, but the evidence was restricted to weight gain. And we found quite a low adherence rate in the trials, and the effect in young people was less clear. And therefore we said, okay, the evidence is 1 for weight gain, but the grade of recommendation can only be 2, because if you look at the published papers, our colleagues had to ask a lot of patients until they agreed to take part in the study, and then the adherence rate was low, and in the end only weight improved a bit, but not the eating disorder psychopathology. Another interesting drug is dronabinol. However, we have only 1 positive double-blind crossover trial published by Andries, and therefore dronabinol got a level of evidence B, but the grade of recommendation 2. It is a controlled drug in the UK, so not every psychiatrist can prescribe it, and it is not licensed for the use in anorexia nervosa. A drug that we couldn't recommend because there are only a few case reports, but a very interesting drug is metroleptin, which is a genetically produced leptin. There are a few positive case reports where metroleptin reduced the level of activity and also improved the psychopathology in people with anorexia nervosa. And this is the results table. And as you can see here, olanzapine is the top scorer with a level of evidence 1, but only a grade of recommendation 2. So the medications I mentioned can be allocated to the anatomical structures of our synopsis as follows. Dronabinol acts at the hedonic system as it is a cannabinoid receptor agonist. Olanzapine influences dopamine signaling. It's also an antihistaminergic agent, and therefore it has an antihistaminergic effect at the hypothalamus, which increases appetite. And metroleptin is a leptin analog, and therefore it signals a certain amount of fatty tissue to the brain, and it can reduce physical activity. Now let's move to bulimia nervosa. In bulimia nervosa, we identified 70 relevant articles. Most evidence was found for fluoxetine, which I already mentioned as a very reliable drug in bulimia nervosa, and the level of evidence was of course A and the grade of recommendation 1. 4 randomized controlled trials with a high quality sign rating found a statistically significant superiority of fluoxetine regarding binge eating and vomiting in people with bulimia nervosa compared to placebo. We also identified 2 randomized controlled trials for the use of topiramate in the dose of 25 to 400 milligram per day. And therefore, we also recommended topiramate. However, I have to point out that topiramate is not approved for the treatment of bulimia nervosa, even though we recommended it based on the 2 randomized controlled trials that were published. It is only approved for epileptic seizures and migraine, and it's contraindicated in pregnancy and in women of childbearing potential if they don't use a highly effective method of contraception. Here you can again see the top medications in green, fluoxetine and topiramate. And for all the other medications, we couldn't find enough evidence plus good acceptability in order to be recommended for their use. So here you can see topiramate and fluoxetine, our top scorers. For bulimia nervosa, topiramate influences glutamate and GABA signaling. It also influences electrolyte channels on the surface of nerve cells. And fluoxetine is a serotonin reuptake inhibitor. Okay. Then binge eating disorder. Yeah, in binge eating disorder, we have a very interesting new development, which is lisdexamfetamine. We have evidence from 4 randomized controlled trials and 1 relapse prevention trial that lisdexamfetamine is effective in reducing binge eating frequency and body weight in people with binge eating disorder. And therefore, we bestowed a level of evidence A and a grade of recommendation 1 for lisdexamfetamine. And we also found 3 randomized controlled trials for topiramate and binge eating disorder. And therefore, we also recommended topiramate. Okay. And here you can see topiramate and lisdexamfetamine and how they influence the self-regulatory and the hedonic system. TAAR1 is the trace amine receptor 1. This is the receptor that the lisdexamfetamine binds to. Now, what about the new eating disorders like avoidant restrictive food intake disorder? We don't have any RCTs for ARFID yet. However, we have evidence from a chart review and 2 case reports for the use of mirtazapine in ARFID. And therefore, we said we can give a very weak recommendation for the use of mirtazapine in ARFID. For pica, we found 2 case reports for fluoxetine. As I said earlier, pica is the consumption of non-food. It is often a comorbidity, and therefore, before I would prescribe a medication for pica, I would rule out that people have obsessive compulsive disorder or a neurodegenerative disease like dementia. And in rumination disorder, we found 2 relevant articles, one testing levosulpirid and one testing baclofen. And levosulpirid is a D2 receptor antagonist with a prokinetic activity. And we have evidence from 1 open study for levosulpirid where 38% of people treated with levosulpirid improved after several months. This means this medication doesn't help everybody with rumination disorder, but about 1/3 of people. Then we also have a crossover study for baclofen. However, baclofen has been reported to have serious side effects like psychosis, depression, balance disorder with faults, and difficulties in verbal expression. And therefore, we thought we couldn't give a strong recommendation to baclofen. Okay, our guidelines have, of course, certain limitations. They are focused on the pharmacological treatment of eating disorders only. They didn't include studies that compared medication with non-pharmacological, biological, psychotherapeutic, or other treatment approaches. Whether a study was successful or not was decided with reference to the main outcome and the improvement of diagnostic criteria. However, other important outcomes were neglected. For example, anxiety and sleep disturbances. And these are really important problems for people with anorexia nervosa, for example. Most people with a very low BMI have sleep disturbances, and some starve themselves because they want to avoid strong emotions, like, for example, anxiety. And we completely neglected patient-reported outcome measures or patient-reported experience measures. And this is simply because these PREMs and PROMs have not been established yet in anorexia nervosa. So patient-reported outcome measures means what do the patients think they need, and what do they want to recover from, and what would they see as an important outcome measure. But this, as I said, unfortunately hasn't been established yet. Comorbidities were also neglected, and comorbidities are really important to consider. For example, bupropion is contraindicated in anorexia nervosa because it leads to weight loss and increases the risk of seizures, which is why if someone has both depression and anorexia nervosa, we shouldn't prescribe bupropion for these people. And then, for example, if you think about depression or bipolar disorder and binge eating disorder, we shouldn't prescribe mirtazapine or olanzapine, because these are medications that additionally increase the risk for weight gain. Also, most of the pharmacological trials in eating disorders have a relatively short duration, between 6 and 16 weeks. And if you develop guidelines, you can only use the randomized control trials that are published and therefore available. Okay, now let's talk about the future of the pharmacological treatment of eating disorders. And I would like to mainly focus on anorexia nervosa, because in bulimia nervosa we have fluoxetine, and we can also recommend topiramate. In binge eating disorder, lisdexamfetamine has just made a great breakthrough. However, there is no approved medication and no medication that we can fully recommend in anorexia nervosa. And therefore, I think this eating disorder really needs some help from psychopharmacology, as so many people develop a chronic and severe anorexia nervosa. Only 2/3, I think, recover, and 1/3 develop a severe and enduring eating disorder or long-standing anorexia nervosa, and they die earlier. Okay, the problem in anorexia nervosa is that people have a decreased food intake as they starve themselves, and they also do a lot more anorexia nervosa related activities. For example, over-exercising, walking a lot, counting calories, etc. If they starve themselves, that induces an immunological response, and we have measured in our group cytokine levels like interleukin 6 and TNF alpha and found that they were elevated. We also found that growth factors like BDNF and IGF-1 were downregulated, and this leads to neuronal and glial damage, which you can even measure, as some neuronal damage markers are increased, like neurofilament light or tau protein. Therefore, neuroplasticity is reduced, the brain shrinks, and we have reduced connectivity. Connectivity is how different cells in the brain are connected. Usually only adjacent brain areas work with each other, because it needs a lot of energy if your left and your right side of the brain have to work together, or if your prefrontal cortex has to work together with the occipital cortex. And particularly in patients with anorexia nervosa, we have reduced connectivity. And this leads to memory problems. Patients cannot remember their identity before the anorexia started. So they cannot imagine where they want to go back to. They cannot see the future if they don't have a memory about how things were before the disorder. It also leads to cognitive rigidity, to anxiety and depression, and therefore neither the psychotherapist nor the patient can unfold their therapeutic potential. We have already heard about dronabinol and olanzapine. They can increase food intake and body weight. And we have already heard about metroleptin that might be beneficial in reducing the increased physical activity that people with anorexia nervosa show. However, there's a new medication on the horizon, which is psilocybin. This is a molecule produced by mushrooms, which leads to euphoria, changes in consciousness, time distortion, perceptual alterations, and spiritual experiences, which is why it's called a psychedelic. And there has been a meta-analysis performed showing the effectiveness of psilocybin in substantially reducing anxiety and depressive symptoms. It improves serotonergic transmission, neuroplasticity, BDNF production, and cognitive flexibility. And last year, there has been one study published by Peck and colleagues in Nature Medicine, which is the first study of psilocybin in anorexia nervosa. And they looked at 10 adult patients at a dose of 25 milligram psilocybin. Here you can see the effect of psilocybin in the brain. And this is from a study of healthy people. On the left, you see the connections between different brain areas. And on the right, you see the connection between different brain areas under psilocybin, which means all the brain areas start working together. And this is why during the psychedelic trip, people can see sounds and have experiences that they usually don't have. And we are currently doing a study testing psilocybin. We'll recruit up to 60 participants with anorexia nervosa. They will be randomized with a 2-to-1 ratio to either 25 milligram or 1 milligram psilocybin. 1 milligram psilocybin is our placebo condition. The primary objective will be to assess the efficacy of psilocybin with psychological support in improving anorexia nervosa symptoms, and secondary objectives will be OCD symptoms and weight gain. And of course, we have a safety objective to assess the safety and tolerability. What I have to point out, people do not just take psilocybin. They will be prepared for the trip in 2 or 3 sessions with a psychotherapist. And then the same psychedelic psychotherapist will sit with them during the trip for several hours to guide them, to make sure they don't develop anxiety and a bad trip. And after the psilocybin dosing session, the psychotherapist will have a few further sessions with the patient to make sense of what they have experienced during the trip and what it might mean for their future. So it's not just the psilocybin. It's more the case that psilocybin is given to improve the specific psychedelic psychotherapy. Okay. We will complete the study on psilocybin this year, and next year we'll start a study testing ketamine in people with anorexia nervosa and depression. Ketamine is an NMDA receptor antagonist. However, it increases glutamate transmission in subanesthetic doses. It has a rapid but only transient antidepressant effect in people with major depressive disorder. It potentially ameliorates neuroplastic deficiencies, And small studies have shown a preliminary evidence of its efficacy in people with anorexia nervosa. However, so far no randomized controlled trials have been performed testing ketamine in anorexia nervosa. And I think the first step is to do a feasibility study, which we are going to do. There are, of course, some case reports on intramuscular, on intranasal esketamine, and one case report has been published by my PhD student, Joe Keeler. Okay, what's the rationale for testing ketamine in people with depression and anorexia nervosa? The rationale is that we have that people with anorexia nervosa often have depression. And people with depression have a poor prognosis because if they don't have the energy to fight the anorexia because of their depression, they don't engage as much in therapy and they don't have hope, and therefore the psychotherapy is futile. This is why we think we need to address the comorbid depression in people with anorexia nervosa, and ketamine is a drug that is already used for the treatment of treatment-resistant depression in the UK. The study design will be a double-blinded randomized controlled feasibility trial in 60 adults with depression and anorexia, and they'll receive twice weekly oral ketamine versus placebo for 6 months. The primary endpoint, however, will be after 4 weeks post-randomization, and secondary endpoints will be after 3 and 6 months. And the primary aims will be, as they are for feasibility studies, feasibility and preliminary clinical efficacy. I think it's important to talk about identity and to talk about other therapies that also improve neuroplasticity. It's not only the psychopharmacology. Also identity-based interventions like mantra or narrative therapy or arts and music-based therapy, they improve connectivity, identity, and also needs to neuronal growth. Likewise do the exposure-based interventions like CBTE or supported food exposure. And then we have therapies that use technology, like, for example, exposure in the virtual reality kitchen, or avatar therapy, where an avatar symbolizes the anorexia nervosa and the patient is instructed to fight the avatar, which means fight it in a symbolic way as the avatar represents the anorexia nervosa. And a new therapy which I would like to mention is cognitive remediation therapy, or CRT in short, as this is a therapy that can be applied in people who are quite underweight. Usually we say, well, a patient has to gain weight before psychotherapy is useful, but we have made good experiences with CRT on our ward, and we have patients on our ward with BMIs between 10 and 13, and then they gain weight up to BMI of 15 or 16, and then our daycare service will take over. Okay, so where do these medications unfold their effect? First, we have to make sure that we provide enough food intake, and the patient might be able to take solid food. If not, we can offer liquid food or meal support. If this doesn't work, we have to proceed to nasogastric tube feeding. Or if the patient vomits everything that goes into their stomach by nasogastric tube feeding, they might need NJ tube feeding, so nasojejunal tube feeding. We can help with the food intake by prescribing olanzapine or dronabinol, and we have also heard that the new medication metroleptin might reduce the physical activity. and therefore we increase the food intake and we reduce energy expenditure, and therefore we have a nice improvement of the energy balance. That means we reduce our immunological processes, our neuroplasticity can improve as well with more food intake. We can also use the new medications like psilocybin and ketamine to improve neuroplasticity and connectivity and treat anxiety and depression. And we combine these biological approaches with psychotherapies like mantra, exposure therapies, arts, music, and CRT. And we hope that this all together leads to a situation where the patient starts eating autonomously. Right. Here you see where ketamine and psilocybin unfold their effect in our biological system synapses, in the memory system and in the self-regulatory system. Now, a lot has been talked about the microbiome recently, and there are several ways how we can influence the microbiome. For example, we can give probiotics. Probiotics are living microorganisms. There are 2 studies using yogurt compared with milk for 10 weeks, and yogurt contains the lactobacillus bacteria. There is 1 RCT using a commercial probiotic versus placebo, and they found a significant improvement of constipation. Then there are prebiotics, which are different from probiotics. Prebiotics are compounds in food that foster growth and activity of beneficial microorganisms. Prebiotics are only compounds that foster microorganisms. They are not microorganisms themselves. Right, and then we have the possibility of fecal transplantation or stool transplantation. There are 2 case reports in anorexia nervosa. One reported no improvement, the other one reported weight gain. Therefore, we do not know whether fecal transplantation will help our patients with anorexia nervosa, but it might be an interesting research idea to keep in mind. Our dietitian Namdo Patka has reviewed the literature and particularly focused on gastrointestinal symptoms in people with anorexia nervosa. And on our ward, we use the usual lactobacillus probiotics to help people with gastrointestinal symptoms and anorexia nervosa. Okay, here you see where prebiotics, probiotics, and fecal transplantation can influence our biological systems. Of course, you can order probiotics on Amazon, and you can also order yogurt or other products that contain probiotics. However, the evidence in eating disorders is low, and the species that are lacking in people with anorexia nervosa, like Roseburia and Fecalibacterium, they are usually not included in the products that you can buy on Amazon or in the supermarket. I would also like to talk a bit about the novel drugs for obesity, because they might have a therapeutic potential in binge eating disorder. And I'm also aware that some people with anorexia nervosa buy medications that help with obesity to lose further weight. And these are the GLP-1 analogs. Now, the GLP-1, that's a molecule that reduces gastric emptying, which means the nutrition stays in the stomach for longer. It increases insulin secretion, It decreases glucagon secretion and it decreases appetite, not only peripherally, but in the brain at the hedonic and homeostatic system. One of the first GLP-1 agonists that we used, and we used it already when I worked in Germany, in Leipzig, at a center for obesity treatment. We mainly used it for people with obesity and type 2 diabetes. Liraglutide, which is a GLP-1 agonist. So liraglutide achieves 10% of weight loss. So you can lose 10% of your body weight by injecting liraglutide, but it needs daily subcutaneous injections. This is quite a lot. And then the new development was semaglutide, where you only needed weekly subcutaneous injections. And this is a bit more effective even. You can lose 50% of your body weight. And we have now even an oral medication of semaglutide. Now, there are now developments of GLP-1 receptor agonists, tirzepatide and retatrutide, which bind to other receptors as well, like the glucagon and the GIP receptor. And with these medications, you can lose 20%, or with retatrutide, even 25% of your body weight over a year. And I think this is fantastic, because this is the amount of weight usually people would lose after bariatric surgery, where they had the size of their stomach decreased. So 25% weight loss, this is really, I think, a breakthrough. However, there are side effects, and these side effects include nausea, vomiting, diarrhea, and dehydration, and potentially bile stones. We have seen thyroid cancer developing in animal experiments. It may not be relevant for humans, but the future will tell us more about this potential side effects. And here you see where the GLP-1 receptor agonists unfold their potential. It's in the hedonic system, in the homeostatic system, and also in the body periphery at the GLP-1, GIP, and glucagon receptors. Yeah, and this is the summary of what we have talked about today. We have talked about olanzapine, which is an antihistaminergic medication that can increase appetite and body weight in people with anorexia nervosa. We have also talked about dronabinol, which is a cannabinoid receptor agonist that might be helpful in anorexia nervosa. I have mentioned the new medications, the psychedelics, the typical psychedelic psilocybin and the atypical psychedelic ketamine. These medications might help with depression in people who also have anorexia nervosa, and therefore instill hope and energy in these people to fight their eating disorder. I've also mentioned topiramate as a medication that might help with bulimia and binge eating disorder. And we have talked about fluoxetine, which is recommended and approved in bulimia nervosa, and lisdexamfetamine. Lisdexamfetamine is recommended in binge eating disorder, and it is meanwhile approved in the United States and a few other countries for the treatment of binge eating disorder. I mentioned metroleptin that might reduce physical activity in people with anorexia nervosa, but also has some beneficial psychopathological effects in anorexia nervosa. And we have mentioned the microbiome-based medications like prebiotics, probiotics, and fecal transplantation as a potential future treatment for eating disorder. And I mentioned, even though obesity is not generally seen as an eating disorder. Nonetheless, these medications bear the potential for the treatment of binge eating disorder. So I've mentioned the GLP-1 agonists, liraglutide, semaglutide, tirzepatide, and retatrutide. I would like to thank all my fantastic colleagues at King's College London and the South London and Maudsley NHS Foundation Trust and the University of Oxford, University of Utah, other universities. I would like to thank my funders and the WFSBP task force eating disorders. And I would like to thank you. Sorry. Yeah, I would like to thank you for your attention.